Good morning, everybody. Thank you guys for being here this morning. We're really excited to kick off what should be one of the opening sessions here at SCCM. And my name is Vance Curo. I'm with Medtronic, and we're also really excited to talk about this particular topic as near and dear to our hearts and our mission of patient safety and equitable care for all. So I've got the pleasure this morning to introduce our speaker. We have Dr. Emily Methangkool, who is a cardiac anesthesiologist with a master's in public health with a focus on safety, quality, and public health. She currently serves as the chair of Olive View UCLA Department of Anesthesiology and the director of perioperative services for the Los Angeles County Department of Health Services, which covers 4 hospitals and serves over 800,000 patients. She's an associate professor of clinical physiology at the David Geffen School of Medicine at the University of California, Los Angeles, and completed her residency in anesthesiology and fellowship in cardiothoracic anesthesiology at UCLA. Since 2013, she has been a faculty member of the UCLA Department of Anesthesiology and has served in many roles, most recently as the vice chair of quality and patient safety. Dr. Methangkool is passionate about patient safety and quality improvement and has written about and spoken on these topics at the national level. She has been published in the New England Journal of Medicine, JAMA, Anesthesia and Analgesia, and the British Journal of Anesthesia. She is the chair of the American Society of Anesthesiologists Committee on Patient Safety and Education, as well as a member of the Anesthesia Patient Safety Foundation Board of Directors, and editor of the APSF newsletter, which has a circulation of over 700,000 anesthesia professionals worldwide. And somehow, within all of this, she has time to be with us here this morning. I'd like to introduce Dr. Emily Methangkool. Thank you.
Thank you, Vance, for that very lovely introduction, and thank you to all of you for being here. I'm really honored to be able to speak here on a topic that I think is very important to all of us. So I am a cardiac anesthesiologist. There may be people who are anesthesiologists here, maybe some not. If you don't know what we do, we take care of patients who are coming to the operating room who need complex cardiac procedures. So heart valve replacements, heart transplantation, lung transplantation. So and we work very closely with our critical care colleagues. So this topic is actually very important to us as anesthesiologists. So I'll mention here that I am a member of the board of directors for APSF. If you don't know what APSF is, it is a nonprofit organization that's primarily focused on education and funding research for initiatives for perioperative patient safety. I'm also the editor of the APSF newsletter, which, like Vance said, has a very wide circulation and also publishes new updates about patient safety in anesthesia and surgery. So in this talk, we're going to be looking at how modern pulse oximeters have variable performance in different racial groups, summarizing some of the scientific evidence on the clinical impact, and also identifying some potential strategies to mitigate the clinical impact of potential disparities in pulse oximetry readings. I think it goes without saying that our patients are very, very sick. As a cardiac anesthesiologist, as you can imagine, I take care of a variety of critically ill patients. But I will say that the patient population that I find personally the most challenging to care for are those who have end-stage lung disease. So not just acute hypoxemic respiratory failure, but those ones who are coming to us and they've all failed all types of other therapies, which may not necessarily be intuitive because you may say, oh, what about the patient who has an EF of 10%? Well, for those patients, we actually have things we can do for them. We can put them on pressors, we can put them on epi, vasopressin, all of these other things. We can put ventricular assist devices in, we can put them on ECMO. We don't have as many therapies for patients who have end-stage lung disease, really except for ECMO. And once they're on ECMO, that can be very challenging for us to take care of them. And in addition to their lung disease, that can also precipitate heart failure as well. A lot of these patients have right ventricular failure, which makes their care very, very complicated. In anesthesia, in the cardiac OR, we are actually dealing with hypotension all day long. A lot of anesthetics precipitate a lot of hypotension. But in these patients with end-stage lung disease, if we're doing a lung transplant, for example, we're contending with both hypotension and hypoxia all at the same time for hours on end, which is really, really challenging. So there was a patient I had not too long ago who was actually coming down to the OR from the ICU for a lung transplant. This patient had a history of end-stage lung disease due to pulmonary histiocytosis, and unfortunately had progressed so far that they were on ECMO, and they were on VA ECMO due to both respiratory and heart failure as well. Unfortunately, once we got to the operating room, we found that we were unable to get a pulse oximeter reading. The patient was on ECMO with a very, very narrow pulse pressure, and it was intermittently reading saturations of 80s or 90s or sometimes not at all. And we tried putting the pulse oximeter everywhere you could think of, the earlobe, the finger, the nostril, that's usually my go-to, nothing. So you can imagine that as I'm trying to take care of this patient who is on VA ECMO, who is potentially hypotensive, on vasopressors, trying to induce them for anesthesia, and also trying to figure out what their pulse oximetry reading is, that can be a huge cognitive burden on the people taking care of the patient all at once. And I think this really illustrates the fact that sometimes we do have to care for patients with incomplete information, and we have to make decisions, unfortunately, with incomplete information. So we actually ended up getting an arterial blood gas and then trended the saturation based on that first blood gas the best that we could. So that just goes to show that, our patients are very sick. They're getting sicker, they're getting older, they're coming in for more complex procedures. There are a lot of treatments and interventions that we have now that we didn't have 10 years ago. And those are very challenging. Those are very challenging patients to take care of. So, for example, a good example would be a patient who had very severe symptomatic mitral regurgitation. 10 years ago, we didn't really have good options for them other than just symptomatic medical management. Nowadays, we can do an intervention in the cardiac cath lab that takes about 3 hours, a mitral valve edge-to-edge transcatheter repair, and the patients have a lot of improvement from that, but they're also very, very sick. So with all of these advancements in procedures and medications and interventions, that has really been driven a lot by technology. And yet, one of the mainstays of technology, which is monitoring of a critically ill patient and pulse oximetry, has actually come under increasing scrutiny over the past several years because we've recently witnessed some of the pitfalls of its use, which really came to a light very much during the COVID-19 pandemic. So for my patient, it was absolutely impossible to get an accurate, continuous pulse oximetry reading. We tried every place that we could. Does anyone want to volunteer what the most creative location they've seen a pulse oximeter placed? The forehead? Okay, that's one. The great toe. Okay, we put that on babies all the time. That's a great place. Anywhere else? The lip, yeah. So I've seen that one is a rare one, the lip, but it does work sometimes. Okay, great. So let's pause here for a moment because I think in order to really get a good discussion of health disparities in pulse oximetry, we really do have to understand how pulse oximetry works. So I'm going to do a very, very brief primer on how it works. I will preface this by saying I am an anesthesiologist. I'm not an engineer, but I think it will be good to frame our discussion. So pulse oximetry actually is not a new technology. It's actually, its mechanism is based on the Beer-Lambert law, which states that the amount of light that is absorbed by a substance is directly proportional to its concentration. And the pulse oximeter as a machine, or rather the oximeter as a machine, has been around in some form since the 1930s. But our modern pulse oximeter was really brought forward by a Japanese engineer. His name was Takeo Aoyagi. And it was really through Aoyagi's work that the pulse became a part of pulse oximetry, because he recognized that pulse variations represented changes in arterial blood and could be used to measure arterial oxygen saturation. Subsequently, pulse oximetry was introduced at the American Society of Anesthesiologists meeting and then became incorporated into basic standards for monitoring in the operating room in 1986. And since then, it has become a standard in every OR, every ICU, every emergency room since then, at least in the United States and pretty much worldwide. So what does a pulse oximeter do? It measures the percentage of functional hemoglobin that's bound with oxygen. And in our blood, you can find oxygen bound to red blood cells via hemoglobin. You can find it bound to dissolved in the plasma, and that's represented by your PaO2. Simply put, your SpO2 is the quotient of the oxygen bound to hemoglobin that's divided by the total sum of hemoglobin in the blood. However, your SpO2 really is just a surrogate marker for your arterial oxygenation, or your SaO2, because your arterial oxygenation is comprised of both your arterial oxygen content, your hemoglobin, and the partial pressure of oxygen in blood. So for patients who are critically ill, who are vasoconstricted with low perfusion, who are septic, who are acidotic, the pulse oximeter may not necessarily correlate one-to-one with your arterial oxygenation. In addition, your pulse oximeter does tend to be a lagging indicator of oxygenation, which I'm sure we have all seen. A good example that we see clinically in the operating room is especially prevalent during lung transplantation, where we are intermittently ventilating one lung and then ventilating the other lung. And I'm sure you can imagine that in a patient with end-stage lung disease, this is very, very poorly tolerated. So in those patients, you will see the cerebral saturation as measured by a cerebral oximeter, as well as the mixed venous oxygen saturation as measured by your Swan-Ganz catheter or your PA catheter. Those saturations will actually go down much quicker compared to the SpO2, and in fact, the SpO2 can be even a minute or longer behind. And what this means is that the patient's actual PaO2 may be in the 50s, while your SpO2 is somewhere still in the 90s. In general, there are two types of oximetry, transmissive and reflectance. So transmissive pulse oximetry is the one that we are most used to in the non-invasive pulse oximeter. Reflectance pulse oximeters are those that we see in our central lines, or our SCVO2s or our PA catheters. Even though pulse oximetry may not be 100% representative of the arterial oxygenation, it is a quick, easy, and non-invasive surrogate measure of oxygenation. So the emitter in the pulse oximeter shines light at specific wavelengths through the tissue, taking advantage of the fact that deoxygenated hemoglobin absorbs light at 660 nanometers, and oxygenated hemoglobin absorbs light at 940 nanometers. The changes in absorption are measured by a detector, and that calculates the proportion of hemoglobin that's bound to oxygen. Red and infrared light are primarily used in pulse oximetry because they penetrate the tissues much better than blue, green, and yellow light. And oxygenated blood absorbs greater amounts of infrared light and allows more red light to pass through, while deoxygenated blood absorbs more red light and allows more infrared light to pass through. So the tissue, the bone, the venous blood actually absorb a constant amount of light. And in contrast, when you have pulsatile arterial blood volume, that changes with each heartbeat, and that also causes fluctuations in your light absorption. And it's those changes that really allow the calculation of your SpO2. So the pulsatile change in the absorbance allows the calculation of a ratio that can be tracked along a calibration curve that converts to an SpO2. And that calibration curve is created from arterial blood gas samples of healthy volunteers. So in summary, you really need pulsatile flow for your pulse oximeter to work. You have to, because the pulse oximeter tracks those arterial blood changes and the periodic variation in LED light absorption. Oxygenated and deoxygenated hemoglobin absorb light differently with red and infrared light, and so the pulse oximeter must be able to read that relative absorption. And the arterial peak absorbance of red and infrared LED light is plotted along a calibration curve to report a corresponding SpO2. So the pulse oximeter really has to have specific calibration curves that are aligned to the LED lights in that particular model. So with all that being said, I think we all recognize how important pulse oximetry is to the care of our critically ill patients. However, are there any randomized controlled trials that have shown definitively that the use of pulse oximetry has decreased morbidity and mortality? Who says yes? Who says no? Yes. Okay, good. We have very limited evidence that pulse oximetry can change outcomes. The largest study was actually all the way back in 1993, so actually 32 years ago, and it does come from the anesthesia literature. They randomized 20,000 surgical patients to pulse oximetry use or no pulse oximetry use, and actually found no differences in outcome. The only difference was that the use of pulse oximetry did allow the anesthesiologist to intervene on hypoxia earlier, but that didn't necessarily translate into any change in outcomes. So there's actually no level 1 evidence to support that pulse oximetry decreases morbidity and mortality. Now, that being said, even though I did write that on this slide, I don't necessarily think that it's a fair statement to make, because it's very difficult to prove that a monitor, any monitor, in and of itself can change outcomes. Rather, it's what we do with the information that the monitor provides. So it's really important for us as clinicians to be able to interpret the information that this monitor is providing accurately and be able to make decisions, clinical decisions based on the information that that monitor is providing. So is there anyone here who would care for a patient in the ICU or in the OR or anywhere without a pulse oximeter? Anyone? No. I think we all acknowledge it's a standard of care. I certainly would not take a patient to the operating room without a pulse oximeter. If my pulse oximeter wasn't working, I'd get a new one or we'd have to change the room. So what factors contribute to pulse oximeter accuracy? I think there are multiple factors. So motion can interfere with the ability of the detector to detect that absorption of light. So that's important. Ambient light can interfere with detection of light as well from the sensor. Anemic patients can have problems with pulse oximeter accuracy, especially in patients with severe anemia. So in hypoxemic patients with low hemoglobin, the SpO2 actually gives falsely low readings and underestimates the real oxygen saturation. However, the data is limited about this phenomenon, so there does need to be a little bit more research. The pulse oximeter is actually not able to distinguish between oxygenated hemoglobin, which is what we care about, carbon monoxide bound to hemoglobin, or methemoglobin. So that's something important to keep in mind. Poor perfusion is certainly a cause for poor pulse oximeter accuracy, especially because the pulse oximeter, as we've just seen, really relies on pulsatile flow. And this is of particular importance in our patients who are on ECMO or who have ventricular assist devices who do not have pulsatile flow or who have very minimal pulsatile flow. And the sensors have to be aligned with one another, otherwise the oximeter might not be detecting the correct light absorption. For example, you really shouldn't be using finger probes on the ear. I see this all the time where people are putting finger probes on the ear because they can't find the ear probes. Pigment is a huge one, so nail polish, when patients have been administered methylene blue or indocyanine green, tattoos, and skin pigmentation can certainly play a role. So with all that being said, let's discuss the effects of skin pigmentation on pulse oximetry. We know just at baseline that there are going to be differences between your arterial oxygen saturation and your SpO2. They're never going to be, or they're not usually going to be, a one-to-one correlation. However, larger differences between SaO2 and SpO2 in patients with darker skin pigmentation have been reported since 1985. So it's been 40 years that we have known about this, and people haven't really paid attention to it until now, really. Andrew Rees has done a lot of this initial work. He found that there were significantly more technical problems in patients with darker skin tones, resulting in the inability to obtain good signals or the frequency of warning messages. In addition, ear probes were found to be less accurate in patients with darker skin tones. So this was from a study in 1990 that said that in Black patients, an SpO2 reading of 92% was commonly associated with significant hypoxemia, a PaO2 of as low as 49 millimeters of mercury, and a higher SpO2 target, or 95%, was required. In addition, inaccurate oximetry readings, more than a 4% difference between your SpO2 and SaO2 measurements, were seen in 27% of Black patients and only 11% of white patients. So again, this study was 35 years ago, so this is not new information, right? But people didn't really pay attention to it until the COVID pandemic, when we really saw disparities in outcomes between different racial groups. This was a study from the New England Journal of Medicine. It was published in 2020, so around the same time as the onset of the COVID pandemic. So the data was collected before then, but I think with the outcomes that we were seeing, a lot of attention was paid to this study. So the authors looked at occult hypoxemia, which is typically defined as an arterial oxygen saturation of less than 88% that is not detected by pulse oximetry. So the pulse oximeter will read 92 to 96%, but the real arterial oxygen saturation is less than 88. So what they found was that Black patients had nearly 3 times the frequency of occult hypoxemia compared to white patients, 11.4% in Black patients compared to 3.6% in white patients. So very, very different. And again, the attention has really been the result of the recognition that Black patients were suffering much worse outcomes from COVID-19 compared to other groups. This was from a study of more than 7,500 patients. The frequency of occult hypoxemia here was 7.9% in Black patients and 2.9% in white patients. And what you can see is that the occult hypoxemia occurs in both population of patients, right? It occurs in white patients as well. It's just more frequent in Black patients. And it's not necessarily just Black patients. The issue extends to other groups as well. This was from a study of JAMA Network Open, and they looked at 87,000 patients, and they found all patients were found to have some degree of occult hypoxemia, with Black and Hispanic patients having the greatest incidence. They also found that occult hypoxemia was associated with greater organ dysfunction and higher in-hospital mortality. Interestingly, in the study, this highlighted another disparity where they found that white patients were actually more likely to receive initial ABG measurements, despite similar SOFA scores to other groups. However, after the first ABG, subsequent measurements were similar across groups. Not surprisingly, the probability of occult hypoxemia increases the lower your SpO2 value. So if your SpO2 is 92%, you're at a 15% probability of having occult hypoxemia. And again, this occurs not only, the probability of occult hypoxemia increases with your lower SpO2 values, but it does occur in all populations of patients, more frequently in Black patients. Occult hypoxemia by itself can exacerbate disparities, leading to both delayed treatment and worse outcomes. So in terms of delayed treatment, there can be lower oxygen delivery rates as well as delayed treatment for COVID-19. Oxygen saturation is very closely linked with the delivery of supplemental oxygen and treatments for COVID-19. Black and Hispanic patients with COVID-19 who had occult hypoxemia are at higher rates for delayed treatment with dexamethasone or remdesivir, and they may have inappropriately low rates of oxygen supplementation. These disparities are exacerbated when you consider that Black patients, for example, are much more likely to develop ARDS after trauma than white patients, and they have higher mortality rates than other groups. So if you throw these pulse oximeter disparities on top of that, that can really exacerbate worse outcomes. One other group to really consider in our population of patients are those who are on extracorporeal life support, so our patients on VV ECMO, VA ECMO, and ventricular assist devices. Pulse oximetry may already be difficult in these patients because of the lack of pulsatile flow, but the problems are going to be compounded by problems with accuracy in patients who have darker skin tones. So there was a recent study last year that actually found that Black and Hispanic patients on ECMO were more likely to experience occult hypoxemia compared to white patients. And as you can imagine, this can really delay treatment in a patient population that is already very fragile. Other worse outcomes include greater organ dysfunction, higher in-hospital mortality, and increased odds of hospital mortality for both post-surgical and ICU patients. So we now have really an accumulation of evidence that occult hypoxemia occurs with our modern pulse oximeters. There is still work ongoing to figure out what some of the other interactions are. So this was a prospective study published last year in Anesthesia and Analgesia. It evaluated the contributions of skin tone, perfusion, sex, and age on pulse oximetry. And it was performed in a laboratory setting. So they got healthy volunteers to sit in a controlled desaturation laboratory and found significant correlations between skin tone and perfusion, but not necessarily sex and age. And in fact, errors were exacerbated in settings of low perfusion. So although this was a prospective laboratory-based study, it does illustrate the fact that when you think about our critically ill patients who are on high doses of vasopressors, who may be very vasoconstricted, these inaccuracies are going to be compounded, and we have to have a much higher index of suspicion and lower threshold for intervention for these patients. So why do we have these errors in pulse oximetry readings? And the answer is complicated and not completely known. We know that the SpO2 tends to be overestimated in patients with darker skin tones, especially at lower levels of arterial oxygen saturation. And this could be due to a number of factors, including possible design issues, inadequate calibration, inadequate standards for device approvals. What we do know is that melanin absorbs more red than infrared light, and in a pulse oximeter, this means that less red light is being transmitted to the receiver, and the result is a misinterpretation by the receiver that the oxygenated hemoglobin level is higher, and that ends up giving you those falsely elevated SpO2 readings. The good news is that the FDA just released draft guidance on testing of pulse oximeters, and this is hot off the presses. It was just released on January 7th of this year. The FDA recommends controlled desaturation laboratory testing to compare SpO2 accuracy with SaO2 with the goal of non-disparate performance across a diversity of skin tones. So what they recommend is using this Monk skin tone scale to determine the study participants with at least 25% of your participants from each skin tone group. And the groups are group 1 through 4, 5 to 7, and 8 to 10, so 3 groups. The FDA also recommends 3,000 paired observations and 20 or more data pairs per participant with a sample size recommendation of 150 or more participants. The accuracy for these pulse oximeters can be assessed via a metric called the accuracy root mean square, which combines both mean bias and precision into a single metric, and the metric for that is less than 3%. So all of these changes really represent a somewhat seismic shift in the approach of the FDA, because the previous guidance in 2013 stated that manufacturers should only include 2 participants with darker skin pigmentation, or 15% of study participants, whichever is larger. So this is very different, and it's much needed. So all of these testing, the laboratory, you can imagine trying to get 150 participants with that number of measurements is going to take some time. So while we are waiting for those tests to take place, how might we as clinicians mitigate some of these disparities that we see clinically in the operating room and the ICU? So this was a recent editorial in JAMA that calls racial and ethnic bias in pulse oximetry a wicked problem. So what does that actually mean? It means that building a better device is not necessarily going to be sufficient to address the entire issue. And wicked problems are those where there are multiple stakeholders with possibly conflicting values and maybe no one solution. So for this issue, we're going to have to make sure we involve clinicians, engineers, researchers, manufacturers, regulatory bodies, as well as patients in order to come to a solution. So in the face of all of this, what can we do tomorrow in our ICU or in our operating room to kind of mitigate the effects of these disparities? So there are a couple of approaches that have been suggested by various authors. One approach is the correction factor. So basically using a correction factor to account for bias in pulse oximetry. So you subtract a predefined value from your SpO2 for patients with darker skin pigmentation. However, you can already see that there is an inherent problem in this, right? So what is that predefined value? What should you subtract and when? That is still a question remaining to be determined. And also the differences between your SpO2 and your SaO2 may vary widely by the model, by the sensor type, by the saturation range, and the differences in measurements are going to be different between healthy and critically ill patients. So how do you decide what that value is going to be? Should you do more frequent ABG measurements? So perhaps we should be collecting ABGs on these patients more frequently so we know exactly what their arterial oxygen saturation is. But as you can imagine, this does not come without risks, right? Because if you are putting an A-line in a patient, that comes with risk. If you're doing frequent ABG sticks on a patient, that comes with risk. Certainly there is patient discomfort. Our patients are very sick. They may have a lot of bleeding diatheses, so there could be bleeding, hematoma. You could potentially incur ischemic damage to these patients. We often don't think about it when we're placing A-lines, but this could, if they have long-term A-line access, that could compromise their ability to receive future arterial lines, which may be needed when they go in for an organ transplantation, or if they need an arteriovenous fistula in the future. And the other question is that if you are doing arterial blood gas measurements in just one population of patients, but not the other population of patients, is that discriminatory? So that's something that we really have to think about. Should we have a higher SpO2 threshold for intervention? So maybe we just give everyone oxygen and we just treat them at a much higher SpO2 threshold. And again, there is a risk versus benefit analysis, right? So what is that threshold? How do we determine what that threshold is? And what is the evidence for that? I think that's very unclear. There's also risks to hyperoxia. There are certain population of patients where we don't want to give oxygen supplementation to. Going back to my patient who is getting the lung transplant, after his lung is transplanted, we try to keep their FiO2 in the operating room to below 40% because increased FiO2 is associated with primary graft dysfunction. So those populations of patients, we don't want to give them supplemental oxygen if we can avoid it. So I think there's still a lot of questions. What we do know is that you have to use the correct sensor for the correct anatomic location. Inappropriate sensor selection has been known to lead to inaccurate oximetric measurements. So the locations that we typically use, fingertip, earlobe, forehead, there are specific sensors that are made for the fingers, the earlobe, and also for the forehead as well, and also for the nostril and the earlobe. So we want to make sure we use the correct sensor for the correct location, and we want to minimize other factors like ambient light, putting the pulse oximeter in a location that there isn't going to be a lot of ambient light, or putting the hand underneath a blanket. Making sure that we minimize the effects of nail polish, putting the probe on a place that doesn't have nail polish, or taking nail polish off, and putting the sensor on an extremity that will not have excessive motion. So what can we say? Well, one is that we should ensure the correct placement of sensors, that we have to educate our clinicians about disparities in pulse oximeter performance in patients with darker skin tones, that we should be considering validating the SpO2 in patients with darker skin, especially when the SpO2 is less than 94%. So we have to have that higher index of suspicion and that lower threshold of intervention. There are certain authors that do recommend getting more suspicious when your SpO2 reaches somewhere between 94%. So we have to do a lot more research on how this affects outcome, and we certainly have to do more calibration and testing for our device manufacturers, especially in our critically ill patients, which do have very different physiology than our patients who are healthy volunteers. So for those who are interested in learning more and potentially working on solutions, I do want to refer you to the Open Oximetry project. This was founded at the University of California, San Francisco Center for Health Equity in Surgery and Anesthesia. The goal of the project is to improve the safety and precision of pulse oximeters in all populations. So it's brought together a wide variety of stakeholders like safety experts, engineers, researchers, manufacturers, clinicians, and regulatory bodies. And in fact, if you go on the website, you can look at what particular model of pulse oximeter you have and see what the testing showed in patients with darker skin pigmentation. So it's a really, really good resource. So pulse oximetry, as we know, it's a critical tool in the ICU, in emergency medicine, and anesthesiology. We as clinicians have to be aware of the disparities that can be present in these readings. Some mitigation strategies include proper sensor placement, as well as verification of marginal SpO2 readings. Other future interventions include identification of pulse oximeters with decreased bias and greater diversity in our testing and calibration population. So thank you very much. I appreciate your all attention. I know this is a very difficult kind of topic, so I would appreciate learning from all of you what you have done in your ICU to address this problem. And I see one.
Very nice talk, thanks. Just one question. Is there any research into a pulse oximetry that automatically registers the tone of the skin and automatically calibrates the...
Sorry, I can't hear. Could you repeat?
Are there any research into pulse oximetry that automatically kind of recognizes the tone of the skin and corrects, based on the tone, corrects the pulse ox, so.
I think that's a fascinating idea. I do think manufacturers should be looking into that. I'm not aware of any pulse oximeters on the market that automatically correct for skin pigmentation, but I think that's a fantastic idea.
Sorry, this is just a question of ignorance. Do you know if NIRS versus pulse oximeter is better or worse from a skin pigmentation perspective? And then also a question about age. So for pediatric populations, particularly those with congenital heart disease, is there any literature on that?
Yes. So there has actually been a lot of studies done in pulse oximetry in pediatric populations, and the incidence of occult hypoxemia is similar in terms of darker skin pigmentation. So it does affect our pediatric population as well. And the problem with skin pigmentation and cerebral oximetry, yes, it does have some effect as well. That has not been as studied as pulse oximetry, but clinically we do see those differences. Yeah.
Thank you so much. So regarding the pulse oximetry project, the pulse oxy project, so what sort of collaborations they are doing, and how they include the centers, different centers, for their studies?
So if I heard the question correctly, it was how is the Open Oximetry Project doing their testing? So they're actually doing their testing with volunteers in a desaturation laboratory. So they're kind of doing their own testing with patients. Oh, how are they collaborating with other centers? I'm not exactly sure whether they are. Yeah.
Hello, thank you for that. Just a question to put two things together. I know you mentioned there's few data comparing like pulse oximeters, the outcomes with using pulse ox versus without pulse ox, and then like the discrepancies in the reading between the races. Have those two ever been linked? Like for example, that 90 studies of the 20K patients, was it ever like a subgroup analysis between the different races, if like within like the Hispanic or Black population, if there was a difference in outcomes between whether they had pulse ox or not? Because if there's a discrepancy in reading, but there's no discrepancy in outcomes,
Right.
then
Yeah.
like more time on the vent or something like that.
Yes, that is a very good question. In terms of overall pulse oximetry use, that study was done in the 1990s, and we haven't had subsequent studies looking at pulse oximetry and overall outcome. I think if we went back and looked at the data from 30 years ago, potentially we could see a difference. But yeah, that would be an interesting question. Next.
So to follow up, if you look at the Periox trial that was just published by Gibbs et al., that subgroup population that actually wouldn't arrest, only I think 15% were hyperpigmented, like African American patients. And if you look at that small percentage who arrested, I think it was at 85% SpO2 or 80% and below. I can't remember the exact details. But if you increase that number of African patients, even though it's statistically already significant, it's gonna make that number even larger. So to follow up with how that would change my practice, I mean, obviously we're all hyperoxygenating our patients as much as we can anyways, but maybe more thoughtful in
Yes.
a certain patient subset with potential drug selection and modality.
Yeah.
Yeah.
Yeah. Great advice.
Okay, let's give a round of applause for Dr. Methangkool for her time this morning. Thank you guys for being here.